Good afternoon, or it may be good morning or evening to some of you. Welcome to everyone. We have over 350 people registered, and I can see we're nearly up to 100 people online already, which is wonderful. I'm David Oliver. I'm a retired consultant in palliative medicine, and I'm honorary professor at the University of Kent. I'm also chair of the EAPC reference group on neurology, and it's that group that has organised this webinar and the one that's coming up in December. We're very pleased to welcome you all here. We've got 3 speakers. I think we're going to have time for some questions after each speaker, and there should be some time to have some general discussion at the end. So do join in, do use the question and answer and the chat for questions. Probably if you can use Q&A, that will be easier. I will be able to pick it out more easily. So as further ado, we'll pass over to our first speaker. Siwan is a palliative medicine consultant in Cardiff, South Wales, who's been a member of the South Wales MND Care Network for the past 10 years. She's going to start our session this afternoon by describing the multidisciplinary clinic set up for MND in South Wales, and then plans to use some case examples from their clinic to highlight the roles. Can I apologise to people across the world? This is a seminar on amyotrophic lateral sclerosis / motor neurone disease. In the UK, we tend to use MND. I know other countries use ALS and sometimes MND. So apologies, we're talking about the same thing. Thank you very much, Siwan. We'll pass over to you.
Thank you, David. Let me share my slides. Hopefully, can everybody see my slides? Thumbs up from David. Lovely. So yes, I was going to make that same apology, and from this slide onwards, I will use the term motor neuron disease and MND because that's just what I'm most familiar with and use on an everyday basis. So a little bit about me, just to set the scene. So I'm a palliative medicine consultant. I'm based at Marie Curie Hospice in Cardiff, South Wales. And this is the view I'm lucky to share on a daily basis with my patients here at the hospice. I have been involved with the motor neuron disease team. It'll be 10 years in January coming now in the Cardiff and the Vale area of South Wales. So we are part of a MND care network, and the South Wales Motor Neuron Disease Care Network was the first network of its kind to be set up in the UK back in August 2012. And prior to that, there was just one care centre in Cardiff covering the whole of South Wales. So it was very patchy in terms of a bit of a postcode lottery, I suppose, in terms of the access that you had to different services. So one of the main aims of the network was to provide standardised multidisciplinary MND care regardless of where you lived in South Wales, with local clinical teams set up to deliver that care as near as possible to the patient's base. So there are 12 of these clinics covering a population of 3.3 million individuals, and we have about 90 referrals across the network per year at any one time. Our caseload obviously is varying, but around about 180 patients. And we support, since the network started, we've supported 1,600 patients. So just this is just a schematic representation of our MDT members. So our core members are in that blue central circle there. Setup is variable across all those 12 clinics. So some of those clinics will have all those members in the clinic room together, seeing patients. They'd go from one room seeing speech and language and dietitians straight through to the next room to see the physio and the OT, and then the neurologist and palliative care in the other room, and respiratory in another room. So it's a one-stop shop. Other clinics, and the one that I'm in, we don't have our allied healthcare professionals in the clinic with us. We have a virtual MDT with them before clinic, and they see the patients in their own home in the community. So we work very closely with them, but just not physically in the same clinic space. I think there are a few key members that aren't in that yellow outer wider box that are really important, and I will touch on both of them today. But one is a clinical psychologist, and that's support that they bring to our patients. And secondly, I think a research nurse or research coordinator, just to because that's often something we find that it's really important to our patients to have access to that. In between clinic, all these people share a common record. So we use an electronic database across the network where we document all our encounters, whether they be email, telephone, or face-to-face with our patients, and lots of email correspondence really in between visits with the professionals, just to help support decision making and communication between everybody involved. This is just a quick graph just to try and demonstrate, it's not the most robust methodology, but we did ask business intelligence team of digital healthcare record in Wales to provide us data on admissions and length of stay for patients with a coded diagnosis of motor neuron disease on the electronic system. And we looked to compare a 3-year period before the network, before the MDT approach was taken, with the same, asking the same question at another 3-year period, a few years after the network had been established. And we can see from here that the referral, the admission rates dropped, both emergency and elective admissions dropped in the latter period, and also length of stay reduced as well. It would be easy to pick holes in this, and there's lots of compounding factors, but I think just as a sort of overall view, I think it does support the MDT approach. And slightly more robust was a systematic review published last year, and this found 6 studies, that they looked at in detail. And in these studies, they showed actually that that survival increased in patients who had received a sort of multidisciplinary approach to their MND care, compared with patients who'd had a pure neurology approach. So given that there's very little evidence out there for anything that improves survival, sadly for our patients, I think this is quite important to consider. So I've mentioned the network, and I didn't explain the funding the network, but the care coordinators that lead care across the network and ensure that standardisation of care and are the main link for patients. They were initially prime pump funded by the Motor Neuron Disease Association in the UK, with a tapered model that over a decade, the health boards, the 5 health boards, which is what we call the NHS trusts in Wales. So the 5 health boards have taken on the funding of those roles. And the network still has a key strategy role, I suppose, and there's lots of us on that strategic group, as well as 5 directors of the network. And every few years we have an SBAR looking at what our goals are for the coming 3 years, if you like, our strategy. And these are our current objectives, recently shared with all the health boards in our area. So we want to maintain and improve regional services. By this, we look to still review all newly diagnosed MND patients in our MDT clinics within 4 weeks of diagnosis, and to then review them on a 3-monthly basis thereafter. From an education and training point of view, the network delivers many study days for health and social care workers throughout the year, as well as annual MDT days for all members of the MDT. Audit is another key area, and the Transforming Care audit, based on the NICE recommendations, is completed by the network on a regular basis, as well as an annual patient experience audit as well, to just constantly look for feedback and ways of improving the way we deliver care across the network. In terms of research, we've recently teamed up with Healthcare Research Wales in the hope that we will be able to use a once for Wales approach for studies. So at the moment, every health board or every clinic area, if they want to take on a study, has a PI within that area. And what we really want to be able to do is to be able to open up more studies and increase our study portfolio by having just one PI for the network, really. And Healthcare Research Wales have got that model for other diseases and other specialty areas. So that's the hope going forward. At the moment, we've got 12 studies open to our patients across the network. 5 are interventional and 7 observational, but we're always keen to increase that. Care pathway guidelines. So we've got network guidelines for the management of cough, gastrostomy, referral insertion, saliva management, and NIV, and a few more that we want to add in the next year, but we review those on an annual basis. Family and carer support. So we run a newly diagnosed day every 6 months in different patch areas of the network, which is an optional invite for any patient and their family who've been diagnosed in the last 6 months. They can come to that, and different members of the MDT will present at that day, as well as expanding our patient pathway as well in the coming years. Psychological support, I'll come on to this in my session. The network was lucky to have funding from the MND for a clinical psychologist for a 3-year period, which was fantastic. Unfortunately, the funding for that hasn't been continued by the health boards. So that's a great loss for us at the moment, but something we still want to achieve one way or the other. And cognitive changes in managing that is another challenge to the network and another focus in the coming years. So what I want to do, as David explained at the beginning, is use some case examples to highlight the roles of the different team members. So Mr. Bronze is a 58-year-old gentleman diagnosed back in 2018, worked at Cardiff Airport, and in fact worked until earlier this year. He had an adapted vehicle and was still able to work in his usual role. He doesn't have a great relationship with his wife, and he himself describes her as unsupportive. Bar the first appointment, she doesn't come. We haven't seen her in clinic in the last few years. And he's really struggling with lots of anxiety around losing his independence, managing, feeling out of control. What if he was stuck on the toilet? The wife's in work, who would find him? How would he cope? Lots of anxiety around toileting in particular because of the mobility difficulties. And our clinical psychologist spent quite a bit of time with him, and her input was really, really hugely beneficial to him. I've just quickly got a screenshot here. Our database allows us to record ALS FRS, the functional rating scale validated for use in MND, at each clinic appointment. And then the system automatically puts that into graph form for us. And so what we can see here is from diagnosis to now, his ALS FRS has reduced, but you can see it hasn't really reduced as a rapid gradient. In fact, a very, very gradual one. So this gentleman is still, has got quite a sort of slowly progressive form of the disease. So this is just a brief summary that the psychologist documented. This is literally just taken verbatim from the database of what the psychologist had written. And I think just goes to show, well, I think when I read this, just went to show for me how valuable the psychologist is. You'll note she doesn't once say, I have suggested. This is all using patient's words. So her role had allowed him really to recognise his own toolkit, I suppose, and find the things that worked for him, and which is why I think we miss having that expertise in our team so much, and are very jealous of the other services that do still have access to a psychologist. This is just taking another paper that was published last year, looking at interviews of 25 patients with motor neuron disease and carers, and the broad themes that came out of that, 8 themes, for looking at things that input into causes of distress for our patients, and for potential strategies for improving emotional well-being. And I don't think any of these, if you read them, will surprise you. They probably feel sort of fairly common sense and self-explanatory, but actually could be really helpful, I think, to use in a session with a patient who is really struggling from this aspect, and giving us some triggers to talk through with them. Next case, this is a female 57-year-old lady who was diagnosed back during the first wave of COVID in May 2020. First symptoms were in February of that year, and came to our MND clinic for the first time via VC, because we were only doing video consults at that point, in June 2020. And from February to June had gone from one limb being affected to all 4 limbs being affected. So we knew that she was changing at a fairly fast rate. She took early medical retirement at that point in June. We got the speech and language therapists and the dietitians in our community resource team involved really early with this lady. Her family were very keen and very anxious about the rapidity of decline here as well. She voice banked in September 2020 and had a peg placed in October 2020, and was then needing to use an eye gaze as a communication aid by June 2021, using the voice that she'd banked back 6 months earlier. She was transferred in August 2021 from hospital, admitted to hospital, second chest infection in a few months, and transferred from there to a nursing home, which was actually out of our area, still within the network, but would have been our neighbouring clinic, but really struggled with the idea of getting to know new people at this stage. And because of the sort of borderline between our area and that area, we did agree to keep her on our patient caseload. And she was still using her eye gaze. I reviewed her at the nursing home 5 days before she died, and she was still using it at that point. Just a brief slide looking at communication in patients with motor neuron disease. More than 80% of patients will experience changes in their speech and difficulty communicating as a result. Fewer of these will present with communication difficulties. About a quarter of all patients with motor neuron disease will have changes to their speech as a predominant early sign. And of course, there are lots of reasons why speech is altered in our patients. It could be related to respiratory problems and diaphragmatic failure and not having that same strength to their voice, or it could be issues with the soft palates, and often consonants are more difficult as well, or the first thing that's noticed to be problematic. So getting the whole entity involved in these patients is so important, ensuring that we don't miss the opportunity to offer voice banking before their voice quality begins to change. But if their voice is already not good enough, if you like, to be banked, there might still be other options such as voice repair, where they have to create fewer statements recorded, and their voice is then mixed with a synthetic voice to create a voice bank that they'll be able to use. Message banking is slightly different, so that there's no sort of synthetic element to message banking, but people may use it to record certain phrases that they would want to be able to use via a communication method at a later point, or they may want to record something like laughter that is obviously harder to synthesize. And there are low-tech versus high-tech solutions really for communication difficulties. So we've got, pen and paper, I suppose, at its simplest form, if somebody's still able to use their hands for that. right through to the more high-tech solutions that our AAC teams would be involved in supporting, such as the eye gaze smart device that this particular patient used. I've got be aware here is just a little reminder, because I think when we are communicating with patients who are using technology to support their communication, it does take much longer. Anybody and everybody on this call who's done that won't need me to tell you that. And I think it's so important that we allow for that and give that extra time that's required, and be, zip our mouth really when we want to speed things up and finish somebody's sentence for them, because sometimes you think, oh, I know what they're going to ask, yes, or I can just start answering this to save everybody time, but we won't always know. And the patient who might say, how long have I got left? If they take a little pause at that point and you're thinking that they're asking how long they've got left to live, and in fact they were about to carry on typing, until I can go outside or until I can eat, then your answer is obviously going to be very different and going to affect the dynamic of that consultation significantly. So really does need that space and time, and to be sure that they've got their points and questions across. Mrs. Copper's another patient that we've cared for. She was diagnosed back in 2015. She had a 1-year-old daughter at the time, and was a primary school teacher. She carried on working for another 18 months after diagnosis. She prompted advanced care planning really early on. First appointment, she started to talk about this and actively wanted to put documentation in place. She was also really anxious that her husband didn't have to make decisions for her, didn't want her family potentially blaming him for refusing life-sustaining treatment, which was her wish. So we actually did a rather complicated thing where her husband became LPA, but then she did an ADRT because she wanted everything that she could think of to be in an advanced decision to refuse treatment, but wanted the backup option that if there was something she hadn't thought of, that her husband would still be able to make those decisions. But then in September 2017, she was under the palliative care team in the community, and she was admitted to the hospice. So that's my base of work, the hospice in the area. So she came in under my care there one Friday afternoon for end of life care, because she had refused a PEG. She didn't want antibiotics, and now she had a chest infection and was ill enough that she might die. But she came in and had a complete change of heart, and was desperate for fluids, was desperate for antibiotics, had a significant improvement in the following 48 hours. And by the Monday morning said to me, I've changed my mind, I want that PEG. By which point she was on, an IV 16 hours a day. And I wasn't sure if we'd missed the boat and things had been left too late to get the PEG in, but she continued to improve, and we did get supported in having a PEG inserted the following month, and then she died at home 18 months after that. Nutrition and feeding, a real area of interest at the moment for motor neuron disease, and lots of links emerging between low BMI and higher risk of developing MND, and also that those with the greatest weight loss have the poorest outcomes. So we know it's a really important area to focus on with our patients, and good dietary advice is key. And some of you may be involved in studies ongoing at the moment, exploring really the value of in-depth dietary advice for patients via the Optic Health study. So this is just pulling across the NICE 2019 guidance on management of MND in this area, nutrition. So the importance of discussing gastrostomy at an early stage and then at regular intervals according with patients' preferences, explaining the benefits of early placement and the risks of not placing or late placement, and paying particular attention to the nutritional and hydrational needs of patients who have associated cognitive impairment. And that moves us on nicely to the next case, Mr. Gold, who's slightly older than the other patient, 75. And he was diagnosed in 2019 with PMA. Over time, we became aware of real challenging behaviour of this gentleman. His wife was saying he's a lot more irritable, he festers on issues, and he finds it really difficult to move on. Our clinical psychologist at the time was able to visit him at home, and she completed an ECAS, and the cut-off scores for the ECAS, both for the ALS specific and the ALS non-specific components, were lower than expected. So we knew this supported our clinical suspicion that this gentleman had some cognitive impairment associated with his motor neuron disease diagnosis. And having this diagnosis by the clinical psychologist really helped his wife to understand the challenges and to adapt her response really to his perseverance with certain issues. And it also prompted a session outside the normal clinic. I do find it quite difficult in a clinic appointment to really produce an advanced care planning document with the patient, because I think it just needs so much extra attention. So I did have a session aside just with the two of them, myself, thinking about all the different aspects. And since then, he's now has a lasting power of attorney in place and a DNA CPR. So in terms of cognition, it is a common feature, more common than lots of people assume really, with a condition that's primarily thought to affect motor neurons. And we also know that 15% of patients who have a diagnosis of frontotemporal dementia will at a later point go on to develop motor issues and receive a motor neuron diagnosis. And then patients with motor neuron, similarly 15% of those patients will receive a diagnosis of frontotemporal dementia. And then there's an additional proportion who will have milder either cognitive or behavioural or both changes. And the sort of cognitive changes that we see are different to those changes that you might see in a Alzheimer's dementia or vascular dementia, and tend to be focused on executive dysfunctioning and language problems as well, in particular spelling difficulties and impaired verbal fluency. In terms of the behavioural and social cognition changes, as this patient had demonstrated the rigidity of thought and the perseverance on a particular issue, difficulty moving on to the next question or to the next task in daily life is something we often hear about, as well as disinhibition and apathy as well to the stress of others around them. And whilst there aren't interventions that can alter the course of the cognitive decline, knowing and understanding why it's happening and being able to offer support strategies to help carers and families can still make a huge difference. And also, as with Mr. Gold that I just described, the trigger to try and encourage early advanced care planning as well can make a big difference. This is just the last case, just to try and bring it all together really in terms of MDT working, because this is the patient that probably stands out in my mind when I think about our MDT working at its best. This gentleman was diagnosed in February 2018, and he, at the first MDT clinic, the respiratory team gases suggested that he was in type 2 failure. Type 2 respiratory failure, so they arranged with a CO2, I think, of 7 point something. It was really significant. They arranged within days to go out and set him up on NIV, and they couldn't, he couldn't tolerate it. Lots of anxiety, panic, just could not manage the device. We knew that without this, he was expected to deteriorate and die in the matter of weeks, really, and supported a life insurance application, etc., with everything with that in mind. Our respiratory team were desperate to try something and ringing around, looking at all the different options, and they managed to get hold of this negative pressure ventilator, a Curas, that he that worked in a different way to the NIV by putting pressure on the chest wall and providing a negative rather than a positive pressure, and worked brilliantly for him. It was considered it was probably just going to be a stopgap. We didn't have lots of consumables and we didn't have a backup machine if there was a problem. So it was far from ideal, but it was, a stopgap to something more permanent. And we were thinking a tracheostomy. He was really adamant that he didn't want a tracheostomy. But because he was doing well on this device, we just kept him on it really, and the respiratory team primarily were, to thank for that. He then needed a PEG and wanted a PEG, and this was a huge challenge because obviously you can imagine that's where the PEG, putting the PEG in, you could get him off the machine shortly, but how were we going to then allow the PEG site to heal and not apply this pressure? And there were so many people involved in planning this procedure, the clinical psychologist and the respiratory team primarily. So, now we were over a year on from him trying the NIV first off, and the psychologist did lots of desensitization work with him with the NIV. And he had that PEG, and he managed one night without the QRAS with NIV support, and then went straight back on the QRAS, and the PEG worked and used it during the day for feeds and back on the QRAS at night. And he died at home with the negative pressure ventilator still in place, with community palliative care team and the respiratory team being the main supporters and providers of his care at that time. And it was just, nobody would have thought that really when we saw him back in that clinic at the beginning of 2018. So what I hope I've tried to demonstrate in my session is that, a multidisciplinary approach to this multi-system disorder is absolutely essential. Good communication between all the members of the multidisciplinary team is another must, and every single member of the team is important. And we know when a member has gone or is off, we really do miss their input greatly. Thank you.
Thank you very much. Do you want to stop sharing the screen? And then thank you very much indeed for that. We've got a moment or two for questions. I'm not seeing anything coming up at the moment. I did wonder, how you talked about gastrostomy. We have had a question asking what is the role of the speech and language therapist and dietitian, and when do you think about gastrostomy?
Yeah, and I suppose in accordance with the NICE guidance, from the very beginning, really, that the idea that somebody, will need to consider whether they want to and what their views are, and it needs to be right from the beginning. I do find that first appointment in clinic is so overwhelming for patients that how much emphasis we put on that in the first clinic will depend on the urgency. So if somebody hasn't lost any weight and hasn't got any other bulbar signs of involvement, we probably don't put as much emphasis on it early on. But yes, early on, introducing the idea, and then the triggers along the way then to rediscuss it, I suppose, when, if there is any weight loss, if there have been any swallowing difficulties or any other bulbar features presenting, that, it would move its way up, I suppose, the list of important things to cover.
Thank you very much. I've got a question just come in. As a caregiver, what is our role in palliative care? How can we be useful to our patients? I'm wondering if that's a social carer who's providing day-to-day care rather than a doctor or a nurse.
Yeah, or potentially a family member carer as well, I suppose. I think understanding their wishes and helping to information gather if they are trying to make decisions would be one of the roles. Appreciating some of the difficulties that we've expressed. So, for example, me giving more time to communicate if they're using a communication aid or if they're struggling with their speech. So being sympathetic to the changes, the multi-system impacts of this condition. I think, I mean, there are so many things. I don't know, I'm sure the other panel members and perhaps Simone in his palliative care session may want to revisit that question as well.
I think we can come back to that. Another question is mentioned care pathway guidelines. Are these available outside your organisation? Were you mainly thinking about the NICE guidance?
Yes, so I mentioned those, didn't I, in the network objectives. So we have our South Wales network guidance on saliva management and cough management and NIV and gastrostomy. Some of those I would say are quite local in the sense that they have email addresses for, you know, for the nutrition team, etc. So they might not all be of value outside. But yes, a few of them you would be able to access without being on an NHS Wales computer. I'll try and find the link for that and pop it in the chat before the end of the afternoon.
I'm asking Joanne to put the NICE guidance into the chat as well.
Yes,
so
brilliant.
The overall. And then one final one in relation to the cuirass. Where did you get this machine? It sounds amazing. That may be.
Well, our respiratory team sorted it. They fought for the funding for it for this gentleman, and for this gentleman it was absolutely the right thing and altered his outcome. It's not, you know, we haven't used it since then on any other patient, because obviously our setup for NIV is way more developed, and you know, we've got all the backup and we've got all the on-site servicing, etc. So it's not our go-to, but I think we would still consider it if we had somebody that met the same criteria as this gentleman. Our respiratory team found the very small company that provided it and dealt with the gentleman directly. So I'm not entirely
ask
sure
locally probably is the moral.
Yeah.
Thank you very much indeed for a super presentation, and we'll now move on to Simone Veronese, if we may, who is a palliative care physician and head of research at the Fondazione Faro in Turin in Italy. He's involved in the national and international groups related to palliative care and neurology, and has a special interest in the clinical use of outcome measures and advanced care planning. And Simone is going to talk about the role of palliative care for people with ALS and their families. I'll pass over to you, Simone. Thank you. You're still on mute.
Okay, can you hear me now?
We can.
Okay, can you see the slides?
But we see all that's it, perfect.
Okay, thank you. So thank you, Devin, for sharing this webinar. Thank you, Siwan and Christina, for sharing the panel, and to the APC for organizing that. And thanks all of you for being here today. So what I've been asked to do is to talk about the role of palliative care for people with ALS MND and their families. And this is what I'm trying to do from a palliative care perspective, of course. And so I thought it was a good thing to start from what palliative care is, because the role of palliative care is improving quality of life. So that's what we have to do. And anything we do is related to improving the quality of life of patients and their families. And the good news is that we have evidence that it works. So we can really improve the quality of life of patients with MND, ALS. And we know it's a big challenge, because as Siwan showed us, it's a very complex condition, and so it's a challenge. But sometimes I see when I'm talking to our colleagues involved in palliative care that we tend to be scared about this disease, and so we probably don't believe so much that we can make difference in terms of quality of life, but we can. So this is the first message, is that we as palliative care clinicians, as palliative care teams, can improve the quality of life of patients and families. So we must present ourselves as a possible good news in a very bad condition. We know that motor neurone disease, or ALS, the way you want to call it, and Siwan showed us, it's a very devastating and progressive condition with problems with cognitions as well. And the median survival time from onset of symptoms to the death of the patient. And remember that in research they tend to consider the same endpoint, death or initiation of invasive mechanical ventilation. And we know very well that when a patient has an invasive ventilation, he's not dead at all. But for research, it is likely he had died due to the trajectory of the disease. It is only of 36 months, so it's a very quick disease. But if we go and see what happens from median survival time from the diagnosis of the disease to death, for example, it's only 14 months, because it takes a long time from the onset of the first symptoms to have a full diagnosis of ALS. And we know that when the time from the onset of the first symptoms to the full diagnosis is short, it means that the disease is very quick and probably survival will be even shorter. So for this reason, we consider ALS a terminal condition, which is not probably a good definition for us working in palliative care, but certainly is a condition that a disease that we have no cure for that, and so we know that prognosis is poor. But another challenge is to define prognosis for the single patient, because what I showed you before are median survival time. But then if we look, for example, at this study, this epidemiological study, reporting data on survival on men and women with ALS, we see that women tend to have a worse prognosis because usually they have the bulbar form of ALS, which has a poorer prognosis. We see that the gap between the first and the fourth quartile in survival is up to 55 months. What does it mean? It means it's very difficult to understand for the single patient what his trajectory of disease will be. So how, which survival time this person will have. So another challenge for palliative care is to understand what will happen in terms of prognosis. And Siwan shows us very well that working together in a network of care, so in multidisciplinary team, this absolutely can help in improving the quality of care. But when we as palliative care providers should be involved, well, with David and the EAPC reference group for neurology, we published a paper on the European Journal of Neurology, and one of the most important evidence we have is that palliative care should be considered very early in the disease trajectory, the same as we talked about the PEG before. So as soon we start, the better we can reach the outcomes that we have. So we can have a better input on the quality of life of patients and their carers. And this recommendation says depending on the underlying diagnosis, because this paper is on overall neurology. But in ALS, we know that it's probably one of the disorders where we have more evidence that an early impact can have a better outcome in terms of improving quality of life and helping patients and families in coping with this disease. And we also know that probably the best way to be involved is not depending on the fact that we are at the end of life, or maybe this integrated palliative care, which can be interesting, but it's the fact that we would like to be involved when we are needed. So when there are specific trigger points that we know that we as palliative care can make some difference. And in the last row, in the last picture of this diagram, you see that there are these trigger points where palliative care can play a role and so have a positive impact on quality of life. And so what are those trigger points? Well, if we look, for example, at this book that David published with Gian Borazio and others, and which you can read from the title, palliative care in ALS from diagnosis to bereavement. So it means through all the trajectory of the disease. But those are important triggers where we can really make some difference. Communication. Siwan talked about the importance of the patient to be able to communicate, but also communication of bad news. For example, breaking the news of the diagnosis, which is a really important point where the way you communicate it, probably the outcome of the patient remaining into a network of care, into a pathway of care, or maybe trying to go outside and finding some magical solution to an impossible disease to be cured, you know. So the way you communicate, and we know that in palliative care we have this skill of being good at breaking bad news. So this is important, but also of course in controlling physical symptoms, because physical symptoms we will see are very many and are very impacting in terms of bad quality of life, but many of them can be really improved by quality care. Psychosocial care, we saw a lot in the previous presentation, the importance of psychosocial care in quality of life, spiritual and social needs, ethical issues, advanced care planning and shared decision making. So what are the goals? What goals do you have? Do you want to have a longer survivor when it's possible, or maybe you are more focused on quality of life, or maybe you are more focused on not being a burden for your care, or maybe you want to stay at home, maybe you don't want to stay at home, you want to die in a different setting. And then end of life care. So the importance that we have in end of life care. Support for patients, families, and for carers. So for the other members that sometimes are not so used in dealing with death and dying and deteriorating, and we as palliative care professionals can help them in dealing with that. And bereavement. Bereavement is very important because we know the bad impact it has on family survivors after maybe an unpleasant death of a patient with such an awful disease. So you can find all of this into this book, which I strongly suggest you to read because it's very comprehensive. So talking about communication and communication of bad news, we know also that we have to deal, and Siwan helped us in the patient's difficulties to communicate. And so it takes time, it takes, you know, it's an activity we know we have to do, and we have to deal sometimes with cognitive changes or behavioral alterations. And so we have to know how to do that. But communication is very important. And for example, when you don't know how to, you could, for example, refer to this strategy, which is called ALS, which it has been recently published, who help us in understanding all the phases of a communication. So what do I have to do? And we, for example, in palliative care, use the spikes method from Professor Bookman, which is related more on cancer, but more or less it's the same. So you need to know you have to do some activities to give important communications and to have an effective communication with the patient and with their carers. So communication is a very important thing we have to do, and we have a role in palliative care. Another important thing we said is in helping people to deal with critical physical symptoms. This is just one of the many studies describing the number and the intensity of physical symptoms that people with ALS have to live with. And we see that the most prevalent is fatigue, and we know that fatigue is probably the most prevalent symptom in palliative care overall, and also in MND. And we know, for example, the role of physiotherapy, occupational therapists, and maybe not too much in terms of drugs, but in terms of care, the importance it has on fatigue, and also managing respiratory issues and nutritional issues in order to improve fatigue. And for other symptoms, we have indication, for example, for medical drug intervention or not pharmaceutical interventions, and we will see some of them. For example, in this publication that you can obviously check, there are some indication on how to treat specific symptoms like sialgia or tenacious bronchial secretions, spasticity, muscle cramps, or for example, cerebrovascular emotional liability, which is specific of, it's a symptom quite specific of ALS when they cannot control laughing or crying, for example, which can be very embarrassing for patients, or depression, anxiety, and so on. And pain, the role of opioids. David showed in his papers how opioids are effective and also safe. Of course, they must be used well. So we in palliative care know how to deal with the opioids. We know their side effects. We know how to tackle side effects. We know how to explain patients the role of opioids and how they can be useful, for example, in pain, of course, but also in breathlessness, controlling cough, and in general distress. So this is another role we have. We know how to do it, and we have, of course, guidelines to use those effectively. And psychosocial needs. We saw some from Siwan's presentation, and sometimes it's very challenging to face so many psychosocial needs from families, patients and their families. We know how to deal with them. We have clinical psychologists, we have social workers. We also, myself as a physician, I train on how to deal with many of them. And we have to help patients to go through those social needs. This is why it is so important to assess those needs. For example, we use the IPOS, which is a very good tool to assess palliative care needs, and then to start specific intervention on different areas. For example, David often talks about the role of sexuality, because these patients, they do not have issues with their, sexual system, and they still have that need, but sometimes it is neglected. They can't even think about that. And if you have them in thinking that, you can really be helpful. And then fears, and then there is hopelessness again, because if they just receive the news that there's nothing they can do, that's awful. But we know there's a lot we can do with them if we help them in assessing them and trying to improve their quality of life. And then there are spiritual needs. So existential questions like, why me? Why now? What have I done to get that? And then the role of faith, the sense of sacred. Religion can be very helpful, but sometimes can be a barrier to deal with such an awful disease. The role of hope, the meaning of what's happening, the value of life, or the fear of death and dying. So if you're not experienced with these patients, often they ask you, for example, as a doctor, as a nurse, do you think there's something after death? And you ask, why are you asking to me? We have maybe we have a spiritual assistant, but they prefer asking you because you're not a professional on that. You're a human being, and it is important. So can we help ALS patients and their families to feel at peace as much as possible? That would be the best outcome, for example, to help them in dealing with their spiritual needs. And then there's communication, and Siwan guided us to many techniques to improve communication. But communication is very important, so we need to start as early as possible to understand the way the patient is communicating, and sometimes using the same strategy. For example, I remember a patient, she wanted to die, and she said, I'm just waiting to have my okay to go to the Netherlands to have euthanasia. And she was writing that because she had a bulbar form of ALS and she couldn't talk. And she was very quick in writing, I want to die, I want to die, I want to die. And our nurses said, well, how can we deal with that? And then one of our team had this idea of sitting next to her, not talking, but start writing. And so we started a relationship writing. So it took a lot of time, but then she started opening herself and saying, I want to go there because I don't want to choke to death. And we said, you will not do that. It will not happen because usually, death in ALS is peaceful. And if you will have symptoms, we know how to deal with them. And so then she changed her mind, and she died after 3 months in our hospice ward. But that all started changing the technique of communication. It took time, but it was very rewarding in terms of this patient quality of life. So this is just an example of how important. And sometimes we feel unease because when we have those patients using, for example, those tables with letters, and you have with your eye to try to see where the patient is looking, and then say the vowel rather than the letter, or maybe try to give a name to the picture to understand what they're saying. Well, the patient is very good. You are not. Usually, maybe the informal care is very good in this communication. So you, for example, as clinician, feel that you are the weak one, and that's important because then you start learning, and the patient understand that you really want to do that. You really want to go to the core of the meaning of the communication. So those are techniques that we, as palliative care providers, should learn in order to start a good relationship and help in communication, and then with that, you can have a better assessment of patients' needs and their carers. Another important thing is planning end of life, of course. We know that end of life is part of palliative care, and end of life is definitely symptom control. So we need to control symptoms throughout all the trajectory of the disease, but above all, at the end of life, we must be very specific and very good in controlling their symptoms. And one of the way of doing that is anticipate crisis. For example, you see the picture that the MND in the UK provides of the just-in-case kit. What is that? It's a box. It's a box we do two parts. One is for the the family care, and the other is for professionals. And into the family care, you have a leaflet, a sheet, which is addressed to the patient, saying to the carer, if you open this box, it's because the patient is having probably some respiratory trouble. So what do you have to do? You have to give him those drops of morphine or drops of benzodiazepine, because that is important to relieve the symptoms. So it will be helpful to control the symptoms. And at the same time, please do call this number, which is the emergency line. When a professional will come, they will open the other part of the box, and they will find another sheet addressing the patient, saying, if you are here, it's because this patient with ALS is having those troubles. He has decided perhaps not to go to hospital, he wants to stay home. And of course, the management of the symptom is the core of our plan of care. So here you can find some vials of morphine rather than midazolam, rather than glycopyrronium, or any symptomatic treatments you want to use, and the way you have to use it. And this works. This is a very effective intervention. And most of the time it's not used, but the fact that it is there, it means it's something. So it's so important for patients and carers, because they know that if they want, they can use it. It will be effective. The patients will not go to hospital, and if we will die, because it not always death follows this intervention, but if it happens, it will be a peaceful death. Otherwise, maybe you can control the symptoms, and then you will reassess the patient. So anticipation of crisis is very important, and it is another specific role of us as palliative care providers. And then accurate planning. What does it mean? We want to plan with the patient and the family about their goals of care. So what do we really want? Some can change their mind. Showed us before patients who start thinking, I don't want that, and then now I want that, I don't want that again. Okay, you can change it, but this plan of care means the patient is at the center of his or her plan of care, and we can do that. In Italy, where I work, we recently, 2017, had this law which is similar to the Mental Capacity Act in the UK. So the patient can say, I don't want that, or maybe I want to start, for example, an invasive ventilation, but then I want to stop it. So if I want to try it, I can do that. And for us as palliative care, it's important to, of course, to plan the care with them, to share their goals of care, and make sure that if they, for example, don't want any kind of invasive treatment, they won't receive it. So this is important. And again, we saw communication with family, patients, and professionals. So I'm going to the end of my presentation just to show you some of the points very important, for example, in decision making with patients and families. So as I said, defining clear goals of care. So if goals of care is quality of life, symptom control, staying at home, not being hospitalized, this is what we do. And if it is different, we have to deal, of course, with different services to see the way it is most effective for patients and families. The rolling tube feeding. So we have already discussed the importance of PEG and RIG in terms of quality of life, and we know that the sooner we can propose it and the patient has it, the better will be in terms of patient's outcomes. The role of invasive or not invasive ventilation, and Christine will talk about that later on. The role of us in helping people staying in their preferred place of care and choose their preferred place of death. And also the role that we have with other carers in terms of our autonomy, advanced statements, and so having the voice of the patient before, for example, a bad cognitive deterioration can happen. So this is it for me, David. Thank you very much. And if there are questions, I'm here. I'm very happy.
Thank you very much indeed, Simone. That's been a very good, and there have been questions coming in all the time. One I think you probably mentioned was the anticipatory medicine. Somebody said what to put in it, and we put the information on the chat so people can look at that. But do you think it could increase anxiety for people, for families?
The fact that we are involved.
Yes, that you're talking about drugs at the end of life. I
know. Well, we know that usually when people think about palliative care, they say, well, palliative care is very good, but if they have to think for themselves, well, it's not. We're not very happy of having palliative care. But I think the problem is the way we present ourselves and the way we are good at at sharing goals with patients. So if we really improve quality of life, I don't think can be seen as a bad news, something that improves your quality of life. So sometimes it's the way we present ourselves, and sometimes it's the fact that I think we ourselves are scared of a death of a patient with MND. Maybe we are more used to see patients dying of tumor, and it seems easier for us. But once we are good and involved in MND care, and we see that we can achieve the same goal, so probably it's better for us to deal with that. So I don't think what is scary is the disease. That's scary, but the fact that we can reduce the bad impact, that can be a good news.
I think even the anticipatory medications, having them there can reassure people that there is something, because they often do fear what will happen at the end of life.
There is something and it works.
Yeah. And one important question was, what advice would you give for a hospice for supporting MND patients in the community when they're limited resources? This is someone from a low to middle income country. Okay.
Well, of course, it depends on the setting you are, and the resources is very important. I think that most people with MND, for example, in our country, in Italy, they die at home, and they die at home because they receive good palliative care at home, so in the community. So I think, of course, hospice care sometimes can be expensive, and it's not always available for everyone. But good palliative care in the community can be very effective and not so expensive. So I think we have to learn and support each other, above all if we have different teams working maybe in an inpatient unit or at home. But I think it is absolutely possible to care for these people at home and allow them to have a good quality of life and good death.
Thank you very much. Thank you, Simone. We'll move on now to our final presentation. And we're very pleased to have Christina Faull, who is a consultant in palliative medicine for nearly 30 years, working at Leicester, an independent charity hospice in Leicester in the UK. She leads the research at the hospice and at the University of Leicester, and among her research interests is improving the end-of-life care of people with ALS, especially related to the use of assisted ventilation. And she will be talking to us about ventilation, the increasing use and increasing issues. Thank you, Christina.
Thank you, David. Can you hear me okay?
No problem.
Okay, and are the slides showing okay?
No problem.
Fantastic, thank you. Well, thanks for the opportunity, and it's great to pull some of the themes together in a very complex and often very challenging part of the care of people with motor neurone disease, ALS. So I'll probably slip into the motor neurone disease parlance, so forgive me in that. Okay, so thinking about assisted ventilation, which is predominantly non-invasive, and I'm not going to talk much about invasive ventilation. We have some indication that in some countries, certainly there is increasing use of ventilation support. So there was a review in the UK through asking neurologists what happened in their practice that showed a threefold increase between the 2000 survey and the 2012 survey of use of NIV in the care of patients under neurologists. It's surprisingly hard to get more information, I would say, about what percentage of patients use assisted ventilation. There's no kind of central registers, is my impression. In Ireland, there was a retrospective look at notes in 2014 to 2019, which found that 67% of people were using NIV, and that had offered a longer survival, which was generally months to years rather than a few weeks. So in terms of endorsing the sort of findings of the seminal trial of NIV versus no respiratory support, in real practice, this does improve survival. I think the 67% of use somewhat surprised me. I don't think that's what we find in our service. I suppose it depends what use means, whether it's use it for a bit and then stop it when you no longer find it useful, or use it all the way through until the end of life. I don't know what it would be in your service or your country, but it's quite hard to find out that information. The evidence was sufficient about the value of NIV in supporting survival, particularly symptom management to some extent, that NICE, so the National Institute for Care and Health Excellence in the UK, have supported its use in its 2016 guidance. It didn't talk about invasive ventilation in that, thinking that there was not sufficient evidence about to weigh up the balance to put out guidance. When we looked at the use of assisted ventilation, particularly wanted to look at the use of invasive, so tracheostomy ventilation, the TV in this little table here, for a paper on tracheostomy ventilation in 2017, we picked up from looking at all the various papers quite a variation in use of either modality throughout the world. So putting all of Europe together, which is probably all of us here, their use may be 3% to 44% of NIV and 1 to 31% of invasive tracheostomy ventilation. And you can compare that with the Japan and US figures. So we know that the UK is a great outlier, really, in terms of tracheostomy ventilation, at one end of the spectrum being about 1%. But where are we on the non-invasive overall? Is that to do with resources? Is it to do with the approach that we take to our patients with MND, the value that we see? Is it their approach to prolonging life with this modality of treatment? I think there are a lot of questions around why such variation. But I know in my lifetime of working in medicine, when I started, non-invasive ventilation didn't really exist and certainly was very rare. I remember the first patient I saw with MND who had this massive machine beside them in the bed, and now it's commonplace to at least discuss it. And probably in my service, around 35% of people will opt to have that support. Now, communication has been talked about in both the presentations before. I like the icon at the top of this little graphic about if you're talking, if you're caring for someone as they come to the end of their life, the importance of communication cannot be undervalued. Communicate, communicate, communicate. And that's both sharing information, listening, and helping people formulate their views on what they might want in the future, and when it comes to the point of them needing to make a decision, whether they align with what they thought they might want or indeed have changed their mind. And we've seen some examples of that. Communication specifically around assisted ventilation. There have been two interesting studies from a team in Australia. One was a literature review, systematic literature review, looking at communication issues about initiation and withdrawal, and one was a qualitative study, again, about initiation withdrawal, and some of the themes that came up from there. So most of the clinicians in the papers and in the qualitative research focused in their care of people around the positives of ventilation, about it helping people to live for longer, about how it does improve symptoms of headaches, fatigue, insomnia, appetite, bad dreams, all sorts of symptoms that it does appear to have a very beneficial effect for. But there was very little focus with people on how it may prolong things in terms of prolonging any suffering that the patient was considering their life was, they were encountering in their life, and about that surviving for longer. Because as we all know, despite the assisted ventilation, the illness itself progresses, and it is mostly the respiratory failure that causes the end of life. And if you're preventing that respiratory failure, then you are delaying life ending. What was also found, I think this is quite stark, that if you have a lot of experience, it doesn't make discussions about end of life and about the potential for stopping ventilation, for withdrawing ventilation, any easier. So it's a tough job, however experienced you are, and that's quite a good thing in a way, because which shows we don't have complacency. But it means that with all tough jobs, we may avoid that. And that speaks to the theme above, that there's a focus on the positive things and less of a deliberate focus on getting to grips with some of the realities that go alongside those positive things. So interesting for you to reflect on your practice. Where are you in your comfort level and in your actual practice about discussing end of life and the role of ventilation and ventilation withdrawal in that? And furthermore, that deciding to withdraw treatment with someone or deciding to have that discussion has really complex challenges about it. So the timing of that discussion, the readiness of the family and of the patient for that discussion, the protocol for doing it and how it's going to be done, maintaining comfort and giving assurance to the patient and the family that that comfort will be made possible through a robust way of undertaking this. I think this is quite an interesting word to use, dreaded, by clinicians. There aren't many things as clinician that perhaps we dread, but this is, it had echoes in this summary of the research work to my own research work and what people described about the impact such conversations, such apprehension of how they were going to undertake this, and indeed the processes themselves was about dread, feeling not only uncertain, but really very uncomfortable and apprehensive about it. And I would say that speaks to my own experience and the reason why I became involved in research in this area. So I think it's really important we reflect on our practice and the things that give us dread, because we need to be brave when this is difficult, complex, challenging, doesn't get much easier with practice. So we need to do something to not only make our own practice better, but our own sense of dread and the impact of that less, and to help in our training of other professionals. What do we do to make this all round better for everyone, including ourselves as clinicians? So have you ever discussed it? And did you discuss it at the beginning when someone was starting their ventilation? What's appropriate to discuss when you're giving informed consent to someone about, okay, we can see that you're likely to benefit from this. Let me talk to you about the things that will happen because of it, the problems that you may encounter in the short term, the medium term, the longer term. What do you describe at points at the beginning, middle, and towards the end? Thinking particularly towards the end, have you ever been involved with someone who's very dependent on it, becomes distressed when they can't use it, becomes distressed cleaning their teeth, giving their loved one a kiss, can't eat anything because they need that there all the time? And how do you have conversations then about choices and options for people? So the NICE guidance that I mentioned talks about what we should offer to discuss with people in the use of non-invasive ventilation, and that we should discuss that maybe at the beginning of the diagnosis of that journey, when you're beginning to monitor respiratory function while you're doing it. What would the implications of something not being good enough, and when that respiratory function begins to deteriorate. It talks about the areas that would be useful to discuss. What are the possible symptoms that someone has and the signs that you'll measure and record, although symptoms is probably the strongest indicator of benefit. How the non-invasive ventilation might improve those symptoms, but can be life-prolonging, doesn't stop the disease progression. Explain other ways or additional ways of managing breathlessness. And then checking with the person, thinking about it. This is the informed consent, understands what it is, what can be achieved, has enough information about the ventilation and about other options to make decisions, both about using it now, continuing to use it, and when they might decide not to use it. And I think this is really important phrase that's in bold here, that explaining to people right from the start that it can be stopped at any time. They can ask for help, advice, that they can be supported if they do decide to stop it, because people will be very frightened if they know that taking it off causes them distress, that this is legal. One of the most distressing things I heard in our research was that people had been under the impression that they couldn't talk to people about wanting to stop it because they had to continue it. To stopping it itself would be illegal in some way. And that was reinforced by some health professionals not understanding the ethical legal context for someone who has capacity or has written an advanced statement about stopping treatment. And then there's a need to make sure that families and carers have had an assessment at an early point to understand and be able to use it, and particularly to flag the opportunity of how would they discuss concerns, how would they come back to people to check that things are okay or talk about what bothers them. And in some services, such as the multidisciplinary team service that really sort of keeps in contact with people, has a caseload, everybody is under safety nets, but for others, they may be given the machine and come back if you need any help, rather than really has a clear pathway for being constantly supported and helped there. And the ethical legal elements are really helpful to consider with our teams. The burdens and benefits of doing things, the burdens and benefits of not doing things. When someone is frail, dependent, has a low quality of life, doing something might give some improvement in quality, but might prolong things without any change in that quality. Even if it improves quality, it may not be something that they wish to do to prolong a time, knowing that their abilities and independence is going to deteriorate. They may prefer to take a different route to managing their symptoms and distress. So just because we can do something doesn't mean we should. And I think all medical legal contexts in the world would support that. But we do have, I think, 99 countries involved in this webinar, and you may all have slightly different or very explicitly different contexts about what is legal and what isn't legal, thinking particularly of physician-assisted suicide. But in terms of the autonomy of someone being able to decide what is right for them, I think that is a general principle of good medical practice, that is enshrined in legality, but do comment if that isn't how you're able to practice or feel your medical authorities support you in that. But thinking about how someone might choose to stop a treatment is quite an eye-opener, really. I know how I might make decisions, but there are lots of different styles in shutting your eyes and being fatalistic to, I don't know, just let it happen. I've certainly looked after someone who ended up in ITU, had never attended his neurologist after the first diagnosis, and then needed a crisis tracheostomy ventilation. And that was the right path for him. In a way, it was better that he didn't have to face ever making a decision, he just did what turned up. But there's lots of different individual styles. Quite a lot of people consider first and foremost the impact of things on their family. There are resources that impact on decisions. The cognitive function we've heard about, and who can make a decision of this complexity in their motor neuron disease needs to be assessed carefully. But I think one of the useful method is to hypothecate with people about future scenarios. It takes the emotionality out of it a little bit, when it's not about you need to make a decision, but it may be just supposing, or some people are in this situation. What would be your opinion about how you might decide in that situation? So using a lot of future scenarios and hypothecating can be a useful way of helping people feel less distressed about facing the future. There are guidance documents available. I'm sure you have your own medical documents from your national bodies in your country. This is the General Medical Council one, which has just been revisited, Treatment and Care Towards the End of Life, which talks strongly about withdrawal of treatments. There is the European Neurology Society, which is 2012. I don't know if there's anything more recent, but I couldn't find anything more recent. And then guidance on withdrawal, which is, no, thank you, David, there isn't anything more recent, which is now 2015, how time flies. So it does feel that some of these need revisiting, given some of the evidence that's now available in comparison to that time, in specific guidance on end-of-life care, whether people choose to stop or continue ventilation. Now, the general medical guidance talk about people finding it difficult to contemplate withdrawing treatment. It's easier to not start it than to start it and then have to withdraw it. Some of the difficulties in withdrawing treatment is because you can feel very responsible for someone's death, because death follows soon after an act of withdrawal, certainly of ventilation, less so of dialysis, for instance, or stopping a peg tube, peg feeding, but certainly with ventilation, it can feel very consequential. So the ethics needs to be thought through carefully and discussed. But there's an edict that we should not let those difficulties overshadow our need to, first and foremost, put the patient at the centre of things. The guidance from the Association for Palliative Medicine, we do have the link for that. It is in front of any firewall, so you should be able to access it. Indicates 5 standards in withdrawing treatment that you can see here. I am moving on fast now, David. I think an essential one of these about symptom management is that there is no one size fits all. There are principles of treatment that certainly fit all and a starting point for the doses of drugs, but they will have to be titrated and individualized. But you need to plan that in advance. And some of it is dependent on how quickly someone becomes distressed when they stop it. But actually, interestingly, it's not always that predictable as to how long someone will live after their ventilation has been stopped. You might think, oh, this is going to be very short because they're so distressed and therefore have such respiratory failure, but actually it can go on for quite some time. So titrate and test before you just remove the ventilation is really important. We have published on a minimum data set that we asked people to submit after they'd undertaken withdrawal using these guidance. So we have 46 data sets, 4 with tracheostomy and 42 with NIV over 3 years, half and half happening at home in a hospice, more or less. And if it helps you to know the sort of context, you can certainly look at that paper. It's in BMJ Supportive and Palliative Care, but the majority of people had subcutaneous medications. The majority needed, or the median needed 2 doses before they tested okay, sufficiently not distressed when the ventilation was taken off for a short time, but some needed up to 9, some needed only 1. One had taken it off themselves before anyone had got there, so they just went ahead and continued that. And about 3/4 of patients, if you've got them settled before you take it off sufficiently, don't need much after that. You can see the total morphine equivalent dose that was needed for the entire process, and similarly of the sedative midazolam is what the majority of people use. But there's quite a range on that. So some people needed nothing and other people needed more than that mean dose. Again, it's helpful when you're having conversations with people to have an evidence base. So the median time from the first medication to being able to remove the mask was about 45 minutes. People with tracheostomy ventilation, those 4 that we had, died within 30 minutes. The mode for 14 of those 42 was about 15 minutes, but there was a big range. So this is all, it's about talking to people about this they may live for quite some time afterwards, we're not sure, but also planning your services for a long period of time to be able to give any medication if people do need that. I think the other thing that a colleague who's been working with me has found during the COVID epidemic of using non-invasive ventilation and CPAP for people in respiratory distress is the impact on the staff of withdrawing treatment. Obviously, this is the COVID situation, but it really made me go back to that. People dreaded it. People are apprehensive about it because it does have a big impact on us. And particularly if you feel ill-prepared, unsupported, that you're being told to do something that someone else decided and it's not necessarily something you agree with, that it's that balance of complex moral actions that you're not really sure, are you balancing them correctly? And that duty of not doing any harm. We've written this paper about moral injury caused by withdrawal of treatment during COVID. And we've identified some protective factors, which I think speak to us. So having experience does make the impact less, although it's still challenging if you remember that initial research, that a debriefing afterwards can be really important. And if you achieve a peaceful death for someone, you feel you've done a good job, that is a mitigating factor for the impact of having to do it. We felt that having training was really important. Maybe we should be doing some simulations of withdrawal, and also about caring for people at the end of life, for people that feel very unsure about that, as happened in COVID. So looking after our staff really came much more prominent in my mind as to what are we doing in motor neuron disease end of life, particularly if we're withdrawing treatments that people feel they're involved in causing someone's death. We need to set up that in a way that mitigates all of that impact. And that's the end of my talk there, David. I think I've left maybe 1 minute for questions.
Thank you very much. Perhaps everyone can come back on the screen. Thank you very much indeed. I'm seeing lots of clapping hands going up in the corner of the screen, so obviously well appreciated. Thank you to everyone. We haven't really got time for questions. There were lots of other things came up, and I'm sorry we haven't answered them. We have got our further webinar in December, looking at palliative care and neurology models of collaboration. That's the 13th of December, same time, same place. And thank you to everyone who's come. Looking at the people who've come, we've gone from Quebec and Brazil right the way through to the Philippines and Malaysia. So it's It definitely is good morning to some, good evening to, if not good night to others. I'd like to thank all the speakers for really stimulating. We will have the webinar will be up as a video in the next few days. I will also discuss with the speakers whether we might have PDFs of the majority of the slides, leaving out some information perhaps which is confidential. So it will be possible. Do share that with other people in your team or your area. And thank you very much to Joanne and the APC for facilitating this webinar. So at just after the time, can I say thank you to everyone, and I hope you have a good morning, afternoon or evening. Goodbye.